afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on Mpox, outbreak response and vaccine effectiveness. My name is Austin Zygmunt, and I'm the Public Health Physician Lead for Mpox at PHO, and I have the pleasure of moderating today's session. Before we begin, I want to recognize that June is Pride Month, a global movement to celebrate and recognize the history, resiliency, strength, and achievements of the 2S LGBTQ+ community. I will mention a few housekeeping items. One, the chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod at any time if you have questions during the session. A discussion and question period will follow the presentation. And if at any point during the session you experience any technical issues, please email capacitybuilding@ohpp.ca. I would like to state that as the moderator of this session, I have no conflicts of interest to declare. So it's now my pleasure to introduce our two speakers for today's presentation, Dr. Dale Tan and Dane Griffiths. Dr. Tan is an associate professor in the Department of Medicine and Institute for Health Policy Management and Evaluation at the University of Toronto. He is an infectious diseases physician and clinician scientist at St. Michael's Hospital, where he is the Options Laboratory in HIV, STI treatment and prevention science. His research focuses on clinical trials and implementation science in the areas of HIV prevention and treatment, STIs, and COVID-19. Dr. Tan holds a Tier 2 Canada Research Chair in HIV prevention and STIs, is co-lead of the HIV Prevention Core of the CIHR Canadian HIV Trials Network, and is a member of the Governing Council of the International AIDS Society. Dane Griffiths is a champion for HIV prevention and sexual health in the queer community and currently serves as the director of the Gay Men's Sexual Health Alliance, or the GMSH. He brings over a decade of experience in the community-based response to HIV and sexually transmitted and bloodborne infections. Under his leadership, the GMSH has established itself as a responsive and impactful capacity builder for HIV service organizations, public health units, and policymakers. In addition to its training and development mandate, the GMSH harnesses the power of digital advertising and content creation to mobilize queer men to take action on their sexual health, most recently during the 2022 Mpox outbreak. So we'll now pass it over to Dr. Tan to get us started.
Amazing. Thank you so much, Austin, for the introduction. Thank you so much to PHO for inviting me and Dane to give these rounds today. And happy Pride, everyone. I hope everyone has a wonderful and meaningful and fun and safe celebration. So just some disclaimers before we get started, as you can see here from PHO. As well, this is a list of my own disclosures related to some of the research that takes place with support to my institution. Before we get into the content for today, I did want to start with a land acknowledgement. We're all in geographically different places right now, most probably. I'm situated presently on the traditional territory of many Indigenous people in Toronto, which is the traditional territories of the Mississaugas of the Credit, of the Anishinaabe, of the Haudenosaunee, of the Huron-Wendat, Chippewa, and other Indigenous peoples. And I think it's really important for all of us to recognize this in every aspect of our daily work, in healthcare especially. And especially in a session that's going to talk about Mpox, which is closely related to another orthopox virus, smallpox or variola, which, as you can see depicted here, was actually used deliberately as an agent of biowarfare to literally eliminate Indigenous peoples on this very land not that long ago. This is not just mythology. This is very well documented in the historical record. You can see some quotations here that I won't read out verbatim, but as you look at them, you can see that agents of the colonial state were deliberately fooling Indigenous people into receiving blankets that were intended to appear as gifts, but in fact were literally being used as agents of biowarfare. One of the perpetrators of this genocidal crime, Amherst, actually used to have a street in nearby Montreal named after him. And ironically, that is right in the heart of the queer village in that city. You may know that that street has now been renamed as Adadigan Street, but I think it's yet another reminder of the very close links between our communities, the risks that populations that are equity seeking, that are vulnerable or marginalized in different ways, can disproportionately be affected by health threats such as epidemics like smallpox, Mpox, and whatever else is to come. What I'm hoping to do in my 30 minutes before Dane moves to his section is to start by describing the changing epidemiology and clinical presentation of Mpox in Ontario and globally, with a focus on the 2022 epidemic, to identify some of the key clinical characteristics of Mpox infection, and then finally to discuss some recent evidence and advances in our understanding of key medical countermeasures, including antivirals and vaccine. So we'll start with the first, and we'll start with a little bit of history. So many of you will, of course, know that prior to last year, Mpox was an infection that was really geographically isolated to a handful of locations in Central and West Africa, shown on the map on the left here, with very, very rare exported cases to other countries. Aside from a major outbreak in 2003 that occurred in the United States, where several dozen people were infected through exposure to these animals here, prairie dogs that were being purchased as unusual house pets that happened to be infected with the animal, it was very, very rare to see this infection, certainly outside of those locations. But that all changed last year. This is a global map that updates, according to the darkness of the color, the number of cases in various countries around the world up until June 5th of this year. And what you can clearly see is that this has become a global epidemic. This is a globally distributed infection now. And if anything, it's actually more so a disease of the Americas than it has been of any other region around the world. Canada has the strange distinction of continuing to be listed as the country with the 10th highest absolute number of reported cases around the world, which is quite remarkable given our modest population size. The United States, Brazil, and some of the other countries shown in dark blue here are among the other leaders. So truly a global epidemic, and something that is likely going to remain that way in the future. Here in Ontario, this is the epi curve through to May 23rd of this year. So again, just a couple of weeks behind. You can see that overwhelmingly the epidemic occurred in the summer of last year, 2022. And yet in the bars, you can see that there is still a modest number of cases that are occurring each week. And the test positivity is hovering in the kind of low single or low double digit percentages. And so it really reminds us that this disease remains here to stay. Many of these cases that are occurring in 2023 in Ontario do not always have a travel history, such that it tells us that this infection is being acquired locally, likely through some subclinical infection, and really reminds us that we need to be on the lookout for this infection moving forward. Overwhelmingly, it has occurred in people who are male, and unfortunately, we do not have a breakdown by cisgender and transgender status. You can see that it's mostly concentrated in younger people in the 4th decade of life, and overwhelmingly in urban areas. But I would say that it's overwhelmingly in Toronto, and even Ottawa has had a relatively modest proportion of the cases in Ontario, given its population size. Fortunately, we have not had very much in the way of really bad outcomes. And certainly there have been a couple of dozen people or so who have been hospitalized almost exclusively in 2022, but fortunately no fatal outcomes. Globally, the case fatality rate during this epidemic since 2022 has been roughly 0.2%, which is an order of magnitude lower than what had been previously described in West and Central Africa prior to 2022. So let's really focus on some of the key clinical characteristics of Mpox infection. I think it's very important for all of us to recognize what this looks like and how it's changed over time, since we are going to need to continue to be on the lookout for this and be vigilant, probably indefinitely. So historically, it had been recognized that the rash of Mpox, which is part of the name of the infection, progresses through this fairly typical progression of lesion stages, which we all recognize for other vesicular infections, starting as a macule, moving to a papule, vesicle, pustule, and then crusting over. And in the diagram on the right, you can see that historically what had been described in Central and Western Africa is a centrifugal pattern, with most of the lesions occurring in the face and limbs. Another distinctive feature that you'll see some closer images of in a moment is this kind of indentation or umbilication, as it's called, in the vesicular or the pustular phases. You can see that as a bit of a divot in the lesion's appearance. And I will say that this is certainly something that we've observed clinically over the last year or so. I'm next going to be sharing with you more and more images of Mpox lesions that we actually observed in patients through the last year. I want to emphasize that these were all images that were taken with the express consent of the individuals in question, in the hopes of raising awareness and educating others about what this disease can look like and the tremendous suffering that it can cause. So one thing that was very distinctive for us as we saw our first cases, and I'm sure many of you saw the same thing last year, was that Mpox lesions would often occur first, not always, but at the site of the body where it appeared that it had first been inoculated. So given that we were clearly seeing this infection transmit through sexual networks of gay, bisexual, and other men of sex with men, that's overwhelmingly what we've seen in Canada and globally. Here is an example, for example, illustrating that concept of lesions over the upper lip, over the inguinal or groin area, as well as the base of the penis in one individual. Likewise, we can see other lesions that were at the site of inoculation on the tongue, on the penis, and the perianal area that really mapped onto the specific sexual activities that people would report that they had just engaged in with another person, such as oral sex, insertive anal sex, receptive anal sex, what have you. Likewise, you can see some of the evolution over time, and you can appreciate how dramatic some of the lesion appearances can be. The extent of lesions can lead to really tremendous pain and suffering. This person went on to develop really traumatic phimosis, difficulty retracting the foreskin, difficulty urinating. Often people describe virtually 10 out of 10 or 11 out of 10 pain, prompting emergency department visits. And sometimes it could be even more disseminated. So here's an example of a person I cared for who I was very concerned about. This was about day 2 or 3 after symptom onset, and already there was a lot of erythema in a macular lesion morphology. I was very worried that if every one of these red spots turned into a pustule, you can imagine how devastating it could potentially be. Another feature that was distinctive was that there was a lot of variation in what the skin lesions looked like, certainly more than the textbooks describing prior experience would have had us expect. So in the same individual, within about a day or 2 of each other, we saw a pale macule on the left, a very clear vesicle with a big erythematous flush around it in the center panel, as well as some pustules on the elbow. You can see how different these lesions look from each other. Another notable feature was that lymphadenopathy was quite striking, often in the cervical area and in the inguinal area, mapping onto lesions being present at the nearby mucosal sites, such as the pharynx, such as the rectum, the genitalia. And this could sometimes be visible even just upon walking into a room and examining a person visually, let alone from palpating it, as you can see in this image here. So together with many other investigators around the world who were seeing some of the early cases of this epidemic, we were able to participate in this global case study, or case series, I should say, which was published in the spring of last year that I would refer you to, that really outlines the specific symptoms that people would experience. Rash, lymphadenopathy, and flu-like symptoms have long been known to be associated with, but the preponderance of lesions in mucosal sites, the pharynx, the rectum, the anal area, the genital area, was really a striking feature of this epidemic. But along with those usual manifestations, when one sees a lot of cases of something at once, one of course can start to see the tip of the iceberg of unusual manifestations as well. And early on, we saw a couple of cases actually of myocarditis that we shared in the literature that had not been previously described. Of esophagitis, that's the image on the left. This is an endoscopic image. You can maybe appreciate a bit of a lesion in the kind of 6 to 7 o'clock area of that image that was biopsy positive for Mpox DNA. And then on the right, in an individual with a red eye, who got referred quickly onto ophthalmology, slit lamp examination quickly showed telltale signs of keratitis, which can be vision threatening. It's really important to recognize the diversity of manifestations of this infection. There have also been cases that are even more severe. Encephalitis has been reported globally, for example, and of course, there is a low real case fatality rate. Now, some of the time that those severe manifestations have overlapped with, of course, folks who have other forms of comorbidity, notably immunosuppression. And of course, in the GBM community globally, of course, there had unfortunately been a lot of overlap with HIV infection. And in this case series, we were able to participate in as well. You can see on the two panels here, the distribution of people with various types of negative outcomes, including death in the peachy sort of color, as well as admission to intensive care or hospitalizations in the purple and blue, respectively. That was really concentrated in people who had low CD4 counts of less than or equal to 100. You can see that on the left panel, or on the right-hand side with high viral loads, so more than 4 logs, as opposed to being undetectable, where such outcomes were much less common. And indeed, it took some time for globally us to accumulate enough data to be able to demonstrate that this was happening. When it did occur, it could be devastating. You can see some really graphic images here of just the tremendous degree of suffering that would have been caused by these deep, large, ulcerated necrotic lesions. On the right-hand side, even dramatic nodular lesions. Notably, the distinctive telltale sign of that umbilication is really accentuated here. You can see this kind of black dot or purple dot that many patients with milder forms, if you can call them mild, that I showed you earlier, being accentuated with very large lesions here, and of course, sometimes even leading to death. In contrast, some of the earlier reports had been a bit more reassuring, right? So because fortunately so many people living with HIV these days do have well-controlled HIV with median CD4 counts, as you can see in the middle column summarizing these reports, in the 600-700 range. Very rare in these reports to have people with high viral loads, such as over 200. You can see, 3%, 2%, 8%, etc. in these various case series. That's part of why early reports suggested that outcomes were similar in people living with HIV, because most folks, fortunately, living with HIV had access to antiretroviral therapy. Notably, those who were not doing well disproportionately were folks who were racialized, were underhoused, were also suffering from comorbid mental health or substance use issues, really underscoring the equity issues that time and time again display themselves as disparate health outcomes when an epidemic comes along. So at that extreme, we can see, very dramatic presentations. But at the other extreme, this virus can also fool us. And here is one of several reports that has reported on the prevalence of completely asymptomatic Mpox carriage. So these are samples that were collected from individuals presenting to a sexually transmitted infection clinic in Paris. These were leftover samples that had been collected from the oral pharynx or the anal rectum to look for gonorrhea and chlamydia. And they said, hey, let's look and see whether there's any Mpox DNA in those samples. And you can see that out of 200 specimens in the bottom box there, about 6.5% did have evidence of Mpox. This was at the height of the epidemic in June, July of 2022. But really underscoring the fact that this can be present even in someone who's asymptomatic. And once again, this may relate to the fact that we're continuing to see low-level infection rates in our own jurisdiction presently, even in folks who do not know that they've been in contact with someone who's had infection or who have not traveled. So as we were observing this clinically last year, we realized how much needed to still be learned. Myself, together with a number of amazing collaborators here in the Toronto area, too numerous to name, but I'll show you their names at the end, put together a number of research studies to better understand this. One of them was a prospective observational cohort study. We called it Mpox, and we thought that was pretty clever at the time. And the key findings were, or one of the key types of findings were related to the shedding of viral DNA in different anatomic locations at different time points over the course of the acute illness. And our findings have been presented so far at the CROI conference this year, hopefully for publication later. But what we observed is very similar to what's been reported in other settings globally, in which the DNA of the virus can actually be detectable in various compartments of the body well out to 4, 5, 6 weeks after symptom onset, sometimes even in the face of the tissue appearing to be normal again, and certainly in the setting of mucosal sites, sometimes even in the absence of local symptoms. That's consistent with the idea of there being asymptomatic carriage of this virus sometimes. So it's important to contextualize this. It's important to understand that you may continue to see a positive swab if you're just sending it off for the DNA testing that's available through PHOL at different sites. Whether this means that it's infectious or not remains to be clearly seen, and viral culture studies in correlation with those data still need to be done. I will share with you, though, some data that, although unpublished, does give you a little bit of a sense of the kind of kinetics of the viral DNA shedding. Shouldn't say viral shedding, should say viral DNA shedding over time. You can see in a series of 232 specimens from a few dozen individuals that participated in another study here in Toronto. When we aggregate them across individuals, we can see that there are a few trends. First of all, that regardless of the anatomic site, it does look like the amount of DNA seems to peak in about week 1. You can see about 7 days in each of these panels after symptom onset. You can see also that it seems to be most elevated, highest in the perianal, rectal, and or genital lesions that or specimens that were collected, followed by other skin lesions in the middle bottom panel, and then followed by other mucosal sites such as the nasopharynx and the throat in the middle upper panel, etc. And once again, as I mentioned before, that you can even continue to see the detectable DNA out to, say, 4 or 5+ weeks in many of these individuals. All right. In the last section, I'm going to spend a bit more time discussing what we're learning and what we still need to learn about key medical countermeasures that include antivirals and vaccines against Mpox. So, very, very fortunately, when this epidemic first hit, and very different from our experience with that other pandemic of SARS-CoV-2 or COVID, we were very fortunate that an existing vaccine was already there on the shelf and had even obtained regulatory approval for use in Canada, called Imvamune. This is a 3rd-generation replication incompetent smallpox vaccine that had been developed over the last few decades, really for use in the biowarfare preparedness context. It had actually been quietly approved during the thick of the COVID epidemic for really that purpose, to protect against a potential threat of smallpox even, or Mpox and other related orthopox viruses. So the product is named Imvamune in this country according to its trade name. It's also called Imvanex or Jynneos in different countries around the world. And we were able, as a result, to rapidly deploy it when the epidemic first took hold in the weeks right before last year's Pride festivals were beginning, but after cases were first being detected. And this is, I think, the first such report, and perhaps some of you might also then have referring to these estimates that came out of Israel in late 2022. They did a retrospective population-based study looking at an integrated data platform that they have serving over half of the population of that country, focusing on the population that would have been at greatest risk, as you can see in the middle bullet point, males on either PrEP or living with HIV with an STI. And then they had data on whether they received vaccine, yes or no, during this time period, and then they followed them up for 90 days to see whether any of them acquired Mpox. And so here's what they found. They found a dramatic separation of the curves, as you can see in the red and blue lines respectively. And there you go, roughly 86% risk reduction in adjusted analyses. So those of you who answered that option might have been referring to these data. And I think that's a reasonable guess. However, there have been critiques leveled against these estimates, not because the investigators didn't do their hardest to try to answer this really burning question, but rather because of an issue related to some residual confounding that I'll try to illustrate to you in a slide in just a moment. And there are some other groups around the world, as I've mentioned, that are looking at this question. But right here in Ontario, I want to do a shout out to these amazing colleagues that are listed on this slide, led by Dr. Jeff Kwong at ICES, who have tried to look in our very own data here in Ontario, where something like 50,000+ doses of Imvamune have been distributed so far, to look at the effectiveness against Mpox. So I'm just going to share a little bit of the findings. This is a forest plot summarizing the vaccine effectiveness estimate for these data that are as yet unpublished for a single dose of Imvamune. And what you're seeing is 4 pairs of estimates. And that's because with an observational data set like this, it's very hard to control for all of the confounding that exists. So to maximize rigor in the approach, our team sought to use 4 different methodologies to try to come up with an estimate. I'm not going to talk through them all in detail. We don't have the time for that, but there's a target trial design, if you're familiar with that methodology, trying your best to simulate the effect of a randomized trial. A simple cohort approach to just look at people and follow them over time to see what happens as they receive their vaccine and then do not get infected with Mpox. And then 2 different approaches to the popular test negative design, which you may have become a bit more familiar with during the COVID pandemic years. Essentially, this is a case control sort of design, looking among people who have been tested for the infection in question. For each pair of estimates, you're seeing an unadjusted and an adjusted estimate of vaccine effectiveness. It's adjusting for things like, region of Ontario, history of other vaccines to get a sense of health-seeking behavior, HIV status, a few other things. And the bottom line is that overall, we're seeing estimates in the 30 to 40% range in the adjusted analyses for a single dose, which is, really an order of magnitude lower than that earlier estimate from Israel had suggested. And some other groups around the world are finding numbers that are in the same sort of ballpark. So why might this be? And I think it's really important for us to understand this. This is the epidemic curve for Ontario once again. And the purple line that you're seeing rise early is vaccine, first dose of vaccine in the province. The orange line is second dose. You can see that we're really lagging with second doses. But what's really important is that you can see it really took some time in terms of calendar time for folks to even start to get that first vaccine dose. And as a result, most of the people who ended up being vaccinated, just because of the timing of this, were exposed to a much lower, what we might call in epidemiologic terms, force of infection than folks who never had the opportunity to get vaccinated at all, circled in the red on the left here. And essentially what this tells us is that there's a certain degree of decrease in the epidemic that probably had nothing to do with vaccine at all. Maybe it had to do with saturation of susceptible individuals in the population. Behavior change, of course, was a major reason that Dane will, I'm sure, speak about in terms of community mobilization. And as a result, to simply ignore that variable leads to a lot of unmeasured confounding potentially in those vaccine effectiveness estimates. Really underscores how desperately we need randomized trials to answer important questions like this, but does temper our sense of just how effective at least a single dose of vaccine might be. Not a reason not to get it. We still see statistically significant results, and certainly we recommend a second dose. But I think helpful, I hope helpful in understanding what we are learning about the effectiveness. Importantly, people who get vaccine can still get lesions, and sometimes those lesions can be very subtle. These are some images that a patient of mine allowed me to take of lesions that he literally was writing off as perhaps ingrown hairs, but did indeed turn out to be Mpox lesions in the setting of having had his first dose of vaccine several days, not more than 2 weeks, but several days prior. So be on the lookout for even subtle lesions, particularly in folks who've been vaccinated. I'm only going to speak about an antiviral called tecovirimat or Mpox very, very briefly. Once again, we're very fortunate that this drug even existed on the shelf and had regulatory approval when this epidemic hit us. So different from the case with COVID. This is what it looks like. It blocks a late stage in the viral life cycle, preventing viral egress from infected cells, recommended for a 2-week course. But I do want to emphasize that once again, we really don't have great data on whether this drug works at all. I'd like to say that although we did absolutely give this drug optimistically and enthusiastically to folks with severe illness, we did so in a sense out of desperation because of the tremendous human suffering that we were seeing, not because we necessarily knew that it would work. And those patients did get better. But I like to point out that the patients who did not get that drug, what happened to them? They also got better. So what we really need is randomized trials. Here in Canada, there is a trial called CTN338 or Platinum Can that's being led by the CTN, particularly out of the lead site at McGill. Sites here in Ontario include the Toronto General Hospital and St. Michael's Hospital that will be rolling this out very shortly. So if you do have patients that are afflicted, please consider referring them to the study so that we can learn about the actual efficacy. And that trial is linked to other trials around the world. There is a document that's put out by the CDC in February that discusses the various drugs that have been looked at, summarizing the state of the art of the evidence. So I'll refer you to that for additional detail, but we don't have time to speak about right now. But suffice it to say that tecovirimat is the leading option that is recommended at this time in the absence of definitive data. And I'll end my comments in just 1 minute. I want to just emphasize that throughout all of this work that I've just rapidly moved through, I want to express my sincere gratitude and just what an amazing experience it was to be so actively connected to and engaged with our own community of queer people of GBM in Ontario and beyond, who were working so diligently and so enthusiastically to combat this devastating epidemic. Dane's going to speak about this in more detail, but I did just want to share this one reflection, which is that early on in the epidemic, I would see news reports such as this one, pointing out that there were a lot of concerns for very good reason about how Mpox could potentially stigmatize queer communities. And I think that sentiment is absolutely true and very, very, very important. And yet I will observe that one of the unintended consequences, perhaps, of that, I think, was that a lot of folks ended up feeling the sentiment that's expressed in that quotation. I've kind of paraphrased at the top. People felt like they weren't almost allowed to say gay. They weren't allowed to say what the epidemiology was telling us directly. And I think that that trepidation is an example of us shooting ourselves in the foot. Very important to recognize the potential for stigma. To me, the solution is not to ignore the truth. I think our community has learned this the hard way a few decades ago with HIV, but really a reason to put the voices of community members first and to privilege and to listen and to engage with community organizations. We're lucky in Ontario to have such a rich CBO sector. Many of those folks are among those who I'm thanking on this slide, among them, as well as our funders and our study participants. But with that, I want to turn it over to Dane, who's going to speak from that perspective in more detail. So thank you so much for your attention. And Dane, over to you.
Thanks very much, Daryl. We'll just wait a moment here for my slides. Thank you to the organizers for the invitation to present today. Daryl, couldn't agree more with what you just shared there at the end of your presentation. Certainly we leaned into naming our community, the affected community in this outbreak. And for simplicity's sake today, throughout this presentation, I'll refer to gay men, and that includes gay, bisexual, and other men who have sex with men. So my name's Dane. I'm the director of the Gay Men's Sexual Health Alliance. Happy Pride, everyone. I know a lot of the organizations we work with are deep in planning mode and preparing, especially here in Toronto, for this weekend's festivities. Before I jump into our work in the response, I'd like to start with a bit of background on who the GMSH is. I think it sort of helps situate us in the provincial response to Mpox. The GMSH has been doing the work of sexual health promotion for our communities for more than 20 years now. We're a provincial serving program, and we work closely with community-based HIV service organizations, many of whom were on Daryl's slide. And these are organizations that are working in communities around the province to promote sexual health to link gay men to HIV testing, support and treatment, addressing other sexually transmitted infections, and addressing the social determinants of health that produce vulnerabilities in our communities. And so, just an exceptional group of colleagues that make up our alliance across the province. And they were really instrumental in collaborating with us on the response to Mpox. We developed campaigns and resources that people working in sexual health can use in their work. And we produce campaigns and content to promote access to sexual health related care in communities. So, have taken up a lot of space in terms of digital marketing, digital content creation. Here we had an infection, an outbreak that was affecting our community. We knew that we needed to act fast to reach gay and bisexual men, to have their trust, and to start to disseminate messages about what was happening in a really rapid and timely way. I would encourage you to visit our website for more information and resources. We have resources for clinicians, information for community members about Mpox, but also other topics as well that are priorities in our work. If we do a bit of a rewind back to May of last year, folks may recall it was really, we were entering the first summer without major COVID-related restrictions in place. Travel globally and across the country had really picked up, and a lot of community events that were previously not happening because of COVID-19 were once again in people's calendars. It was in April, early May, that we began to hear reports from Europe, particularly large circuit party events, events in which sex was taking place on site, that cases of Mpox were being reported. And we knew that we expected that there would be challenges that our community would experience in terms of access to appropriate information and care, not because those services and supports don't exist, but that we're a big province with a lot of services. Navigation can sometimes be challenging, and we felt that there was a role for us to help with coordination, support people who are on the front line, and to develop resources to promote access to care. So drawing on what we knew about Mpox, as well as our own lived experiences and lessons from COVID-19, we quickly created a set of resources, and we published those on May 20th. And there was a significant amount of uptake from gay men who were increasingly hearing more about Mpox and wanting to learn more and to share that information. I'll speak to a few of our early response activities. And again, I have to credit Daryl. We're so fortunate here in Ontario to have clinicians and scientists like Daryl who were paying attention to the outbreak, but also beginning to study outstanding questions that we needed answers to in terms of the experience of Mpox in our community. And so we started with community mobilization, and that included bringing relevant stakeholders in clinical and community care to the table, which were literally weekly meetings throughout May and into June, bringing them together to update the situation, to understand where we were sitting with case counts, what the provincial case counts were looking like in different communities, and to strategize on the response and to align all of our collective resources. There were critical things that public health was paying attention to. There was work that we knew needed to be done on the communication side. And I would say all in all, they were incredible moments of solidarity amongst a pretty wide group of individuals. We benefited from having, for example, managers of bathhouses and other sex on-premise venues join those meetings. There were feedback loops that occurred throughout the early days of the outbreak response. to unpack questions, for example, how could public reporting avoid unintended, stigmatization? What referral pathways needed to be in place so that it would be easy for gay men in our communities to access testing, to isolate if they had tested positive for Mpox? And what were the preferences of community organizations and gay men for vaccination? And so, we were fortunate to work with national colleagues at NASTI who rapidly developed guidance on immunization programs for the country. And we were able to directly inform, as members of the affected community, accessibility and feasibility standards in those guidance. In terms of communications, we really never shied away from naming gay men as the affected community in this outbreak. It was overwhelmingly the case. We understood early on that there was sort of a sexual dynamic to transmission that was happening, and that the potential for misinformation and stigma were high. So we fulfilled a role as spokespeople for media relations related to the outbreak, and produced a campaign which I'll touch on in a moment. And all of this was happening in the lead up to Toronto Pride, which of course brings hundreds of thousands of gay men from across Ontario and really from around the world to the city. So time was of the essence. So given our role in coordination and our early work in developing messages, the GMSH developed a full-scale community outreach campaign and supporting the work of public health units and community-based organizations in reaching our community. So this occurred, of course, in the head of Toronto Pride. It was sharing critical messages about Mpox, the availability of vaccine, which we were so fortunate to have very, very early on. And it contributed to our communities vaccinating in pretty large numbers very early on. You can see here some examples of some of these early campaign resources from last year. Simple plain language summaries of the science were really important. Taking a nimble approach, so we were able to react quite quickly, particularly as language was evolving. So of course, early on, we refer to monkeypox, no longer the case, and aligned our language with the global community and the WHO. I would say we were really quite responsible in terms of our disclosures to the community about what we knew was happening and what we knew didn't, particularly early on when there were questions about transmissibility, vaccine effectiveness, the impact on gay men living with HIV. These resources were developed into more than 8 different languages. So thank you to Toronto Public Health for supporting those efforts. And they were distributed throughout Ontario and throughout different Pride events. We ran the ads for the campaign on 11 different platforms, including dating apps, social sexual networking apps, places where we knew we could reach gay men. And we worked with party organizers and other large events, for example, the International Rugby Tournament in Ottawa. So looking back, we were just looking at our stats for this campaign over the last couple of weeks. Our ads were served over 74 million times between June 2022 and March 2023, resulting in 680,000 site visitors in the province to our webpage, which had really useful information about, how to take care of yourself during Pride, what to watch out for, where to get vaccinated, what the vaccine eligibility was, and so on. And of course, the campaign evolved as the outbreak evolved. So whether we were referencing, particular events or travel that was occurring, we were pretty agile in our approach. And we were fortunate to work with artists, performers, and community leaders to relay messages in our communities and to influence getting access to the vaccine. So, thanks to all of these queens here you see on your screen, who did a really wonderful, wonderful job of taking public health messages, but delivering them in such a way that our communities would pay attention and would act on the information. I think it goes without saying that gay, bisexual, and queer men really sprang into action in this response, sharing their experiences, posting on TikTok and on social media platforms, their experiences of, lesions, of pain and suffering, and of course, changing behaviors as well, whether that was limiting their number of sexual partners, taking a pause from some of the apps that we use to connect, to sharing information with our partners and with our friends and loved ones. I think we, gay men really stepped up as our best advocates, organizing and insisting all over the world on access to testing, treatment, and care. And it certainly made a difference. In summary, I would say that the community-led response to Mpox has been really central to the success of efforts that we've experienced in Ontario. We are finalizing an evaluation of the collaborative response between all of the various stakeholders that worked in the response here in Ontario. We look forward to sharing the findings of that evaluation over the coming weeks. The affected community really was the most effective messenger. And so I think it helps foster transparency, open communication, and collaboration. I think it's a reminder that when individuals trust information, they're more likely to act on that and to seek out care and to seek out vaccination, for example. And that our communities possess all of the valuable knowledge, cultural insights, and resources that made a big difference in the response. So the community leaders, the public health officials, the staff from, bathhouses, the party organizers, folks really working together under one mission, which was to ensure that our community's health was protected and that we were informed about the situation and could easily act on access to vaccination, et cetera. And so my thanks to all of our collaborators over the last year. As Darryl mentioned, we still continue to see cases here in Ontario, particularly in Toronto. We're still paying attention to Mpox and sharing messages in the community about, getting your second dose, getting your first dose of Imvamune if you have not yet, being vigilant this Pride season. And I'm sure, like over the last year, community will continue to do its part. So thank you so much. And I will turn things over to Austin, who is going to facilitate some Q&A for us. Thank you.
Okay, well, thank you, Darryl and Dane. So we will now move on to the Q&A segment of this event. A quick note to our attendees to enter your questions into the Q&A pod. So we'll start with the first question for Darryl. We have a few questions about your viral shedding data slide that you presented, Darryl. So one question was around asymptomatic carriage, something you could speak to a little bit further?
Sure. Thank you so much to the questioner. I think the question is about whether or not we think of this carriage as long-term carriage or not. And so I apologize if I insinuated as such. No, we certainly do not think that that's the case. We clearly do see that people clinically recover, and it does look from our own data and from data published from other settings. Notably, there's a nice paper from Spain that have looked at the time it takes from symptom onset until you can no longer detect Mpox DNA in various anatomic compartments when you collect samples from them longitudinally over the course of the illness. And it does look like it eventually goes away. So the average time in this Spanish paper was about 25 days for skin lesions, and our data are very similar to that, although I don't have the final number from our own data. And that is the part of the body that seems to take the longest to clear from. It takes a little bit less time to clear, for example, from the pharynx, from the rectum, but up to 25 days on average was what the finding was in the Spanish studies, and not long-term carriage. In terms of stratifying by symptom status, those analyses are again underway. I think the key message to take away from what we know so far is that it can be present even in the absence of symptoms, right? So we've seen that in studies of asymptomatic viral DNA shedding, and even in people who are symptomatic, you can sometimes see virus in a compartment where the person doesn't complain of symptoms.
Thank you, Daryl. And so as we wait for some more questions to come in, I'll pose a question to Dane. So we have Toronto Pride coming up this weekend, although it's a whole celebration in Toronto through the month of June. The big events are this weekend, Dane. So what's the community thinking about Mpox as we move into Pride season this year?
Absolutely. I mean, certainly we've been hearing from some folks in the community who are still getting vaccinated, folks who maybe, put it off for a period of time, knew Toronto Pride was coming up, knew that they were going to be maybe more sexually active and wanted to seek out their second dose. Fortunately, we still have, community clinics taking place, like at the 519, and, great availability of vaccine for folks who were maybe waiting it out a little bit.
Thanks, Dane. So Daryl, we have a question on vaccine effectiveness. You provided some data on the 1 dose of vaccine. Have we seen any data on the effectiveness of 2 doses?
Yeah, thank you for raising that important question. So important to emphasize the point that, first of all, this is a vaccine that is recommended for administration as a 2-dose series, 28 days apart. It happens to be that there are not that many data on that because we initially rolled it out in Ontario, in Canada, and in many other jurisdictions as a 1 dose to start, given uncertainties about the scale of the epidemic and the amount of supply that was available. So there are some estimates on that nevertheless, and they range from around kind of the mid-60s to the mid-80s in terms of the percentage risk reduction. But a couple caveats. First of all, is that's still a fairly wide range, 65% to 85%, and notably, the studies that provided the higher estimates in the 80s, mid-80s% range are also studies that had an estimate for single dose effectiveness that were considerably higher maybe than the ones that some of the other studies that have tried to more rigorously adjust for confounders have come up with. All that to say that perhaps this 85% is also a generous and maybe overly optimistic estimate. The other caveat is that, of course, all of these are observational data, right? We do not have the gold standard, which would be RCT data. There's still the potential for a lot of unmeasured confounding in all of these estimates because they're all based on just observational data only.
Thank you, Daryl. So we have another question on the eligibility of the Mpox or Imvamune vaccine. Are you able to speak to that? If not, I can provide a link in the chat to the populations currently eligible.
Yeah, since we're running low on time, maybe Austin, go ahead and share that. And I will just say that at this time, well, since the onset of the epidemic, really the data are so overwhelming that the risk is greatest in communities of GBM who have potential for exposure through sexual activity and through sexual networks. And that is therefore how the eligibility criteria were drawn up. However, those who are close contacts can also access the vaccine on the basis of being a close contact. In addition, though, the National Advisory Committee on Immunization is looking at Mpox vaccine again this summer, so updated recommendations are likely to come out soon. See another question. Maybe I'll quickly jump to Austin, shall I?
Sure, go for it.
In the chat, thank you, about second dose recommendations in the context of actual Mpox infection. And at this time, the recommendation is to not administer an additional dose. The thought is that an Mpox infection itself is probably one's best bet. Not that one would want that to happen, but against subsequent infection. Nevertheless, even that is not foolproof. There have been at least 1 or 2 case reports that I've seen of folks who really, truly seem to have had true Mpox infection more than once. Actually, just one that I'm remembering. So it can happen. It's exceedingly rare, however, and as such, that's the recommendation, but it's not necessary.
Okay, so why don't we end it there for the Q&A today. As we wrap up today's rounds, I'd like to extend a special thank you to Daryl and Dane for presenting, and also thank all of those in attendance for today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try and complete this to help us improve our programming. And lastly, to access past PHO rounds and view upcoming sessions, please visit the PHO website and head to the Education and Events tab and click on Presentations. So thanks again, Daryl and Dane, and have a wonderful day, everybody.